I'm Phoenix and welcome to my YouTube channel. This is your girl Catherine Minor. Please call me Kate Mimi. If you haven't been to this channel, I'm a registered nurse in the United Kingdom from Kenya, and we discuss health conditions. We have been taking particular attention on kidney disease. So that's what we do every Monday, and a day that is not a Monday, I don't like committing myself to what date it will be. I just know Mondays are very sacred. We do health education, and any other day it's all about healthcare workers. So chillax, let's talk about dialysis. That is where we stopped last. Again, thank you to Phoenix for continuing to subscribe to my channel and listening to what we are discussing. So last time I thought I didn't give you much more information pertaining to hemodialysis, and I think this is a very good chance for us to have that discussion. See, I'll talk once again and tell you that when it comes to dialysis, hemodialysis, this time we are going to use a machine that is a machine outside the body, and it's going to have an artificial kidney. It is the dialyzer. This is an artificial kidney. It's called a dialyzer. Now, for this to happen, patients usually go to a hospital, okay? They always go to a hospital, but what is happening nowadays is that people are installing machines in their homes, and we are doing something called home hemodialysis. Now, for this to happen, Team Phoenix, there is something that you need to realize, okay? You need to realize that we need, first of all, to have an access. An access, what it simply means is a means to get blood from your body system to the machine and to this artificial kidney for it to be cleaned. So this access can come in form of a wee tube connected to your heart, tunneled under the skin, right here, tunneled under the skin, and we call it a catheter. And then we can also have a more permanent one called a fistula. Now, what happens with a fistula is that surgeons use a vein, usually on your arm, a vein and an artery, and they join them together to create one very big vein. Okay, remember, what we need is a mechanism to help us pump blood outside your body, and also to pump blood back to you once we have cleaned it. Is this making sense? See, we have the heart. So our heart work is to pump blood, isn't it? Now, suppose that we get blood out of your system. How else are we going to return it after we have cleaned it? Basically, that is the question we are trying to answer. So what happens with this big machine that has pumps is that we use your heart to pump blood outside, but then again, we're going to use the machine to pump blood after we have cleaned it in the artificial dialyzer, and that is the artificial kidney called the dialyzer, to pump it back. So remember that this is a process that is happening simultaneously. So at no point will we say that blood has been removed from your system completely. It's now in the machine, and now we are waiting for it to be clean for us to return it. So it continues seamlessly. So it is leaving and returning, leaving, getting cleaned, and being returned. And when we say cleaning of blood, remember, we are removing toxins, we are removing excess fluid, we are removing waste product of metabolism and things like that. So that is just what it means to clean blood. And why do you clean blood? If your kidneys have failed, it is not for everybody. So if you're watching this video for the very first time, kindly do not get confused. We are dealing with people whose kidneys have totally failed, and they are in what we call end-stage kidney disease or stage 5 kidney disease. So ladies and gentlemen, what we do is that we need something that is going to sustain the high pressures that are involved in a process of dialysis. So we have a catheter, and we also have a fistula, either a fistula or a graft. Now, when it comes to a graft, it is a wee tube, It is a wee tube, just an elastic silicone tube or whatever material it is made from nowadays. We join the artery and the vein, to make a very steady mechanism or a steady path for blood to flow when we insert the needles for dialysis. And now I feel so guilty. I think I need materials to demonstrate what I'm talking about. Phoenix, if you look at this video on YouTube, I'm just looking at a YouTube video. This is a dialyzer. This is what we're calling an artificial kidney, and it has fluid that we're calling a dialysate or dialyzing fluid, if you please. And this is the fluid that is going to help us remove waste products from your body, from your blood and back to the bloodstream. So you can see this patient has a very big artery here connected to a vein. It's called a fistula. So we put 2 needles, which are going to help us remove blood. As you can see now, blood is coming, and then it is going to be cleaned within the dialyzer, that is the artificial kidney, it's going to be, you see, waste products, and then it is going to be returned. Look at that wonderful mechanism. You see, so we need something to help us take blood out of you, clean it outside, and then return it. Okay, that is just what happens, simply like in native kidneys. Team Phoenix, the other access I've talked about is actually a catheter. So what is a catheter? It is just a long tube with 2 lumens most of the time, sometimes 3. And a catheter is different. Catheters are different because we have urinary catheters. Probably you're familiar with those. When people have urinary retention, you know, they cannot, void, they cannot urinate normally. What do we usually do? We put a tube, you know, to help them relieve the obstruction of urine or whatever it is. That's a urinary catheter. Now, when it comes to a catheter that we're putting in the heart, it's called a central venous catheter. I want you to remember that it's called a central venous catheter. You will find this mostly in ICUs because in ICU we want to deliver medication, sometimes food and other very many things, you know, fluids and things just crisscrossing the patient's body. So we are trying to put this catheter as close as possible to the heart. Now, this is the same catheter that we use for hemodialysis. It's called a central venous catheter. And I want to show you another wee video here. I really hope that it makes sense for you to understand what is happening with the central venous catheter. So Team Phoenix, this is a catheter. It's also called a central line. And in dialysis, people can call it a PAM cath, that is a permanent catheter. So we have this very long tube and we have 2 lumens. Why we have 2 lumens is because, remember, just like in a fistula, we need one way to get blood from the patient and another to return blood to the patient, okay? So that is the central line, as you can see. And we can place it on either side, either on the left or the right, okay? As long as we get all the way to the heart. So there is a cut, and that is how we insert. See the veins, the large veins that we go all the way near the heart, all the way, so that we can get blood from the heart. Yes, and then we tunnel it under the skin. So what you will see is that this tube will now be outside the skin. That is what you're going to see as the people who are watching. As you can tell, hemodialysis is a blood intensive process. We are coming into contact with blood all the time. That's what you need to realize. So many things can go wrong, and we have to be very honest about this. Number one, when we are looking at that catheter, if you have really checked it out, I'll try and link that video here. If you have checked, is that we are taking an artificial thing and introducing it to the heart, you know. So if we can get an infection anywhere along that tube, it is going to be serious. So we have a very high risk of infection when we are dealing with permanent catheters or central venous catheters for dialysis, or just dialysis catheters. What we try to do is put dressing all the time. We cover the dressing. As the patient, your responsibility is to make sure that it does not get wet. And if you're going to swim or you're going for a jacuzzi, for example, try and use waterproof dressing on top of it. We usually have waterproof dressings. You can always buy some, and then you cover the whole thing, because you don't want water getting in there. You also don't want things like, you know, dirt and filth, anything coming in contact with that tube, because it is a high risk for infection. That's what we want to avoid, because an infection that is coming through the catheter, it is going directly to the heart. So you will end up with a severe form infection we call sepsis. And sepsis is a very, very dangerous condition. And then if we continue mixing it with an underlying condition of kidney disease, then we are preparing ourselves for disaster. The other thing is that your dialysis will not be able to function well, because you will be shivering, you will be feeling, you know, you're just very sick when you have an infection that is a line-related infection, or a catheter-related infection for that matter. The other thing that can go wrong is that sometimes those lumens fail to remove blood. So when we put in a syringe and we're trying to withdraw some blood, it becomes quite sticky. You will find that in different centers, what happens is we have medication that we put inside to help it, you know, to help anything like a clot that has formed to dissolve, okay? But sometimes all those efforts are in vain, and we have to remove the catheter and put another one. So the solution here is, as fast as possible, if you are eligible, if your veins are still okay, you need to have a permanent access, and this is a fistula, either a fistula or a graft. Now, this is the reason why we need to introduce, more seriousness when it comes to follow-up of kidney disease, because patients with diabetes, for example, when they are in stage 3 kidney disease, this is where we need to start having a conversation about creating a fistula. Why? Because diabetes has a tendency of destroying the veins of a patient. So you will find that they now need dialysis, but you don't have veins to use, you don't have arteries to use. Yes, they are there, but they cannot be relied upon. Remember, I told you it is a surgery that we are performing, an artery and a vein joining them together, so it becomes quite distressing. So we need to follow people up quite often so that we can identify their need for dialysis early enough, and then we can allow the process of creating a fistula. And a fistula takes about 6 weeks to mature, so you can imagine what will be happening for these 6 weeks. But if we create it early enough, by the time the kidneys will have totally failed them, then we will be ready with a fistula, which is a rather permanent mode of accessing, in dialysis, of access in dialysis. The other problem that we have is we can have dislodging of the needles. That is when you're putting the needles in, they can come out, isn't it? So you need to be very careful. Your nurses are, of course, very well trained people, and the techs who are dealing with you, those needles need to stay in place. We have different mechanisms of monitoring those needles when you're on dialysis. And some people, like I know in my country, it is very difficult to get those machines to monitor whether the needles are still in place. So it is your responsibility as the patient. If you're on dialysis, please try and be still as possible. Keep that arm still. We keep on checking the needles, and your nurses will keep on checking the needles. If they are leaking or anything, blood is coming out, you need to let somebody know, okay? Let someone know. Although in my unit, what I know we do is that we're very keen, and we use different machines to monitor whether the needles are still in place. So those are some of the dangers that can happen with catheters and with fistulas. I've not gone into details about them because they are rather complicated, and I promised you, Team Phoenix, that I will be doing my best to speak in a plain language and not those medical jargons, isn't it? Dialysis as a whole, that is hemodialysis as a whole, has a high risk of having low blood pressure when you are on dialysis. Okay, so remember, we are getting blood from you, taking it to the machine, and also returning it at the same time. That imbalance can easily make your blood pressure drop. And how will your blood pressure drop? You will start feeling dizzy, you will start feeling flushed, you might even want to vomit or feel like you want to have a bowel movement. Those are signs of low blood pressure. Its greatest complication is actually hypotension. Hypotension is low blood pressure when we are on dialysis, because we are getting blood from you, putting it to the machine. That imbalance really just sometimes destabilizes your blood pressure, and it can quickly drop. What happens is that we need to be very careful, and in the next session I'm going to let you know what you can do as a patient or a relative to make sure that we can reduce the risk of getting hypotension during dialysis. Remember, it is not completely unavoidable because of the fact that we're getting blood from you, taking it to the machine and returning it. But there are things that we can have a wee chat about that can help you actually to take care of your blood pressure when you're on dialysis. So I really hope that you understand the different accesses which you have talked about today. That's a fistula or a graft, and also a catheter. That is, you can either call it a central venous catheter, a permanent catheter, or just a dialysis catheter. Okay, and you have known that we have a very high risk of infection with those catheters, and you have known simple ways to take care of it is to make sure it does not get wet, there is no dirt around that place, and your nurses will always change those dressings. I would be categorical and say that you need to have those dressings changed each time you go on dialysis, but I'll be lying. Why? Because there are different products in the market. We have dressings that allow you to have that dressing for a whole week, and then change it. We have dressings that have to be changed at every session. So it really depends with what dressing is being used, okay? So I will not tell you that, oh, it has to be changed all the time, or oh, it does not have to be changed. No, it depends with what product is your unit using, okay? Let us get that on out of the way. You have also known that we have a risk of bleeding out when we put those needles, and it only calls for keen, attention from both the healthcare providers, that is myself, and you as the patient on dialysis, or your loved one, whoever you came with. We need to keep an eye on those needles. We tape them, yes, we put them securely and everything, but anything can happen. As a patient, what you need to do is try and remain still on that as much as possible, okay? And the other thing we've talked about is that we have a high risk of hypotension, and hypotension is a very big topic that I will want to talk about next time. So Team Phoenix, thank you for attending my wheel lesson here. Thank you very much for your continued subscription, and until next time, toodles.